Let's now go ahead to discuss the first case that was presented. Okay, this is the history where the important points in the history are highlighted in blue. Okay, all these are the important symptoms that are highlighted in blue. Okay, now let's analyze the symptoms and come to some form of diagnosis. Okay, analysis of symptoms are here: age, swelling, the right lower abdomen for 5 years, easily pushed back, the swelling recurs, the swelling disappears on lying, very important, highlighted this one, reducibility, and then it's increasing in size over the last few years, painless, and pushed back manually. So looking at it, the problems in the symptoms is a 61-year-old male patient, progressive groin swelling, which is painless and reducible. So the possible causes will be an inguinal hernia, can be direct or indirect, which are more likely, inguinal lymphadenitis, safena varix, femoral artery aneurysm, superficial causes such as cysts, sebaceous cysts, and lipoma. Of these two, the inguinal hernia is the most common, most likely diagnosis. Now, let's come to the questions that were asked. First question, what are the significant points in the history? The significant points I've already mentioned earlier, and this is a complete list of the significant points in the history. Age of the patient, swelling lower abdomen 5 years, initially as a small swelling which was easily pushed back. Swelling recurs more frequently with time and it gradually increases in size, and important thing, it is painless and the patient lives in a terrace house, single-story terrace house. Question number 2, what is the significance, if any, of the patient staying in a single-story terrace house? This will facilitate the post-operative ambulation for a hernia patient. Question number 3, what is the most likely diagnosis from the history? Inguinal hernia. Now we come to the physical examination and the signs, which also in this slide I've underlined all the important signs on in blue. These include the list of significant signs. Okay, swelling in the right inguinal region, prominent on coughing, gobbler shape localized to the right inguinal region, soft and mildly tender, and very important is reducible. Okay, the important thing is reducible. What is a reducible swelling and what is its significance? Reducible swelling is one that can return into the abdominal spontaneously or when manually pushed back. Question number 3, what special exams or tests you will perform to confirm the diagnosis of this patient? Okay, I'll do the finger occlusion test, the 3-finger occlusion test of Zeeman, digital scrotal evagination test, and also examine to see whether can get above the swelling. In the case of a inguinal scrotal swelling. Okay, these are the important physical signs on physical examination. A summary of the signs here. The important thing is a swelling right inguinal region, 5 by 5 centimeters in size, more prominent and coughing, globular in shape, soft, mildly tender, and reducible. The important word here is your condition is reducible and cough impulse positive. So from this, the history and the physical examination, the most common or likely diagnosis will be an inguinal hernia, either a direct or indirect inguinal hernia. Okay, this is the patient with the swelling in the inguinal region. Okay. Describe the physical findings in this patient. Okay, this patient has got the elongated swelling in the right inguinal region, extending from the inguinal region right into the upper scrotum. The skin above it is normal, and it is maybe about 4 by 3 centimeters in dimension. No skin changes, and the skin over it appears to be soft and non-stretched. What are the differential diagnoses of an inguinal mass? Okay. Okay, inguinal hernia, both direct and indirect, lymphadenopathy, a cyst, aneurysm of the subfemoral artery, and safina varix. Name the investigations to differentiate one from the other. The clinical test includes occlusion, evagination, and 3-finger Siemens test or cough impulse. And if necessary, an ultrasound scan can be done in cases where the diagnosis is doubtful on clinical examination. What are the complications of inguinal hernia? Incarceration, irreducibility, obstruction, strangulation, and gangrene, with perforation and septicemia. We come to question number 3. What is the surgical treatment of a reducible inguinal hernia? The answer is surgical repair. Surgical repair is the only treatment that is available for hernia, and it is called herniorrhaphy, hernioplasty, or mesh hernioplasty. It is done either by the open method or through laparoscopically. Question number 4. Name the complications of hernioplasty. Okay, hematoma, post-operative hematoma, wound infection, nerve injury, especially the superficial nerve, this is the ilioinguinal nerve, and bowel injury. And the most common complication is recurrence. Question 5. What are the most post-operative instructions or advice will give to the patient on discharge? Patient should take a good diet for proper wound healing, adequate rest so that the healing can take place without interruption. Although early ambulation is important to reduce the chance of other complications like deep vein thrombosis, and very important, avoid lifting of weight, at least for 3 to 6 months. Okay, these are 3 patients. This one has got bilateral inguinal hernia here, bilateral inguinal hernia. This is the hernia we talked about, indirect inguinal hernia, and this is a woman with a direct hernia. What are the differences between these two? Okay, here you can see here the lump is very tense, the skin is stretched over it, although there are no skin changes. Okay, and here the skin is loose, no skin changes, and there are no signs of any pathological changes under the skin. Here probably is a sign of an strangulated inguinal hernia, which can be a direct hernia or a indirect inguinal hernia. Okay, this slide shows you the difference between direct and indirect inguinal hernia. Okay, in direct inguinal hernia, you see here the deep inguinal ring and your superficial inguinal ring. The hernia comes into the inguinal canal through the weakened posterior inguinal wall, and then it can travel down, and most of the time it localizes here. In some cases, it can come out through the superficial ring and go into the scrotum and become a inguinal scrotal swelling, which is not so common in a direct hernia. In an indirect hernia, the intestine invaginates or herniates into the deep inguinal ring, passes the whole length of the inguinal canal, and then very often it comes into the scrotum through the superficial ring. So chances of indirect hernia being inguinal scrotal swelling is much higher than in a direct hernia. The clinical test that can be done is a 3-finger test, also known as the Siemens technique, where the index finger, the ring finger, and the middle finger and the ring finger are used to occlude the internal ring or deep ring, the external ring, and the fossa ovalis or femoral ring. In the ring occlusion test is by using your fingers to press over the deep inguinal ring and see whether the hernia comes out or not on coughing. If it does not come out, then it is a positive inguinal occlusion test. This is the scrotal invagination, where the little finger is used to invaginate into the inguinal canal through the scrotum. Okay. These are the important landmarks that you must be familiar with when you examine an inguinal patient, a hernia patient, inguinal hernia. Okay, this is the pubic symphysis here. There's an imaginary line from the pubic symphysis to the anterior superior iliac spine, and this is known as the inguinal ligament. And the midpoint of this ligament is the mid-inguinal point, okay, which is the site of the inferior epigastric artery, which comes out from the femoral artery. The other line is a inguinal ligament attachment from the pubic tubercle to the anterior superior iliac spine, and the midpoint of this ligament is known as the midpoint of the inguinal ligament, above which 2 to 3 centimeters above the midpoint of the inguinal ligament lies the deep inguinal ring. Okay, so the deep inguinal ring is lateral to the superficial inguinal ring, okay, and it is lateral to the inferior epigastric arteries. Okay, here again, ASIS, pubic symphysis. The blue line is the inguinal point. This inguinal line here. Okay, and the midpoint of this line is the midpoint of the mid-inguinal point. Okay, this is the mid-inguinal point. And whereas this is the ligament, inguinal ligament from the ASIS to the pubic tubercle, and this is the midpoint of the inguinal ligament is here, and above which 2 to 3 centimeters above which lies the deep inguinal ring. Controversy over the location of the deep inguinal ring, whether it is the mid-inguinal point or midpoint of the inguinal ligament, is mainly academic, clinically not very insignificant. Thank you very much.